Today we'll talk about neurosurgery at the edge. One surgeon, one nation. In many countries, neurosurgery is a specialty, but in the Gambia, it's a national responsibility carried by a single physician. Today, we explore what it means for patients and the health system with Dr. John Jabang, the only neurosurgeon and the first neurosurgeon in the Gambia. How you doing, Dr. Jabang?
Hey, Dr. Samson, nice to be here.
So, can you tell me a little bit about the burden of neurosurgery disease in the Gambia?
Yes, thank you so much, Dr. Samson. And I'm glad to be here on this podcast. Like you said, I have been just a neurosurgeon for the past 10 years. And I was the first Gambian neurosurgeon. By 2 years ago, we luckily have another Gambian that joined me in neurosurgery. So yes, coming back home, let's say 10 years ago, the burden of neurosurgery was great, ranging from traumatic brain injury, which of course is very high in the Gambia. As you know, the Gambia range is among 4 in the worldwide. I think we are number 4, number 6 when it comes to trauma and trauma-related injuries. So the trauma rates in the Gambia are absolutely very high. Then to congenital malformations and hydrocephalus, of course. Then to neoplasms like brain tumors, neurovascular lesions, neuroinfections like abscesses and all that. So you can imagine a country of 2.5 million without a neurosurgeon. That was really very, very important for the country. And as a result, too, government spends a lot of money in trying to pay for people to go abroad, overseas for treatment. Of course, one can also do that for everybody. Most of the people who would need it, who obviously fall within low level of means in terms of their financial capabilities, can't afford it. And so they either have to live with a disease or die with disease. And a few of them that could afford, it is really very few, whose families can send them abroad, we go abroad for treatment. Yes.
Okay.
So
what does a week look like for you?
So a week is hectic. For me, it's looking at emergencies that are coming, especially traumatic brain injury, spinal cord injuries, because the neurosurgery team here also is responsible for spine surgeries. And then it's also about cases that we book for our OR cases, which range from traumatic injury cases to tumors to infections, spine cases. Also, within the week, we do our rounds. We have ward rounds for patients that are admitted. And we are also responsible, especially in the academic side, to sometimes guide the students. So sometimes we can have, and now we've taken Fridays as our academic days. That's when we guide our thesis, for our students, try to work on some few projects. So usually the week is tight. And of course, when you're done with the work in the government facilities, you sometimes do have some private, work to do. And that obviously makes the week very, very tight.
Okay. In terms of when the patients present, how often are patients presenting too late?
Yes, so late presentation in the Gambia, like most African countries, is a very common phenomenon. First of all, many of the people still believe on traditional practices. So for instance, if you want to go disease by disease, so let's say hydrocephalus. Initially, people's concept of hydrocephalus had some spiritual connotation. And so there are people that feel that such type of children should not be brought to the hospital. They need to be kind of treated outside. And so by the time we review them, either the hydrocephalus have gotten so much severe that even post-surgery, the outcome wouldn't be as good as if you had caught them earlier. So those group of people also do come late. You still have other people. You have people that probably is having a tumor and just sitting at home, just having some headaches, and also is, has to go for local treatment. And before they will come, that also could be late. And that also do happen even with some kids that have brain abscesses that would really come until it is so big and voluminous. That's really a common presentation, that we see around.
Okay. What would you say are some of the biggest limitations in terms of system constraints. We're looking at like ICU, CT, MRI, or access, anesthesia. How would you rank those things?
Yeah, so things have changed a little bit and have gotten a bit better. Going down to memory lanes, and which is very of great interest to you. I remember when Marge first reached out, after having spoken to you, Marge of Global Neuroscience Foundation, about the possibility of getting oxygen for the Gambia. And I took that with a passion because of my very experience. I had then returned from Tel Aviv, having done my pediatric neurosurgery fellowship for 2 years. And I came back and I had big challenges. At that time, there was no mechanical ventilator in the entire hospital. At that time, they only depended on some oxygen cylinders. And this was industrial based. It's basically not even like the medical oxygen that really you want. You have provided. At that time, if I do a surgery, if I have a patient who comes with a Glasgow coma scale of 8 and below, I cannot intubate him and put him in the ICU at the time. Later on, then moved on to having, try to look for things and try to ensure that we get mechanical ventilators. The story was that, and I went to the central medical store, and lo and behold, there were mechanical ventilators, and I'm like, okay, we need to get these things fixed because I need them for my patients. Now, fast forward to that, when I had the mechanical ventilators, 2 of them that were fixed, sometimes I can't put my patient in those mechanical ventilators because the ICU intensivists would say, we don't have enough cylinders, because if I put him on these mechanical ventilators and the cylinders run out, then it's like a death sentence for that person. So I would rather not put him there. So I had gone through those. And you can imagine as a neurosurgeon having no patients. You come in, this patient have a glaucoma scale of 7, it's an epidural hematoma, they came late, let's say more than 48 hours, you went in to do a craniotomy, and you are back, the patient has to breathe by himself. And I would say that was also really one of the reasons why when your project came in, I just really took it up so passionately because I surely knew that it was going to be a game changer for me. Now, today, fast forward to today, it's no longer a problem. So when I have patients, I send them. And today, fast forward today, what is now my problem is now having more mechanical ventilators because they still have, like, they say 3 mechanical ventilators. And sometimes I want to do a brain tumor and they're saying, okay, well, will we need, I'll say, yes, we will need an ICU. After they say, oh, well, the 3 mechanical ventilators are full. But again, this is where we've moved from. We've actually moved from a very long way. If you look back forward from 2019, when I recently came back, late 2018 to 2019, to now, a lot of things have changed. And it has basically made my work a bit easier, even though we still need more things, more.
So it's kind of like the building blocks of things.
Yes.
First step, it doesn't do any good to have more ventilators if you don't have oxygen. You can't have oxygen unless you don't have we can stabilize the energy situation. And now that the oxygen and for your facility, the energy is more stabilized. And by the way, our team will be providing increased support for the hospital by stabilizing specifically the oxygen delivery system. That even though we have some protections to protect it from the power surges from the grid, we're going to solarize it to further isolate it from both the power failures and the power surges that the grid does, which kind of over time deteriorate the electronics of the oxygen delivery system. So we're not done. And we also have one of our pediatric anesthesia fellows. Her name is Gifty Anjaman, and she has been awarded an American Society of Anesthesiologists grant to basically study the impact of installing a pediatric ICU ventilator in the Gambia. And of course, in order for her to do that, she has to obtain a pediatric ICU ventilator to study. The grant doesn't cover that, but we have a volunteer fundraising campaign to try and raise money so that she has that. So all of that is part of the impact, so that the study is one aspect, the ventilator for pediatric ICU patients is another aspect, and then studying the outcomes is a third aspect, all of them contributing to strengthening the health system. And as she's studying it, she'll be partnering with Gambian counterparts, and then they will also be benefiting from the exercise of doing research there in the Gambia, furthering the research aims of the Edward Francis Small Teaching Hospital. So I just want to also acknowledge that the entire oxygen delivery project, bringing that to the Gambia, starts with you, Dr. Jabang, because you were advocating for it. You connected to me through Marge Rattel, who's president of the Quilaboo Neuroscience Foundation, and made the strong case that this is something 100% needed in the Gambia. And it was because of that advocacy that brought me there, that connected me to the Ministry of Health, that connected me to the leadership at the Edward Francis Small Teaching Hospital, and ultimately brought in an oxygen delivery system which pipes oxygen to every clinical area of the hospital, and also using technology that is advanced and uses 30% of the energy requirements of other technologies, and which brings medical air to the bedside of every location and brings wall suction to the bedside of every location as well. And all of that started by having somebody who is dedicated that said, I'm not going to just become a neurosurgeon and go to wherever else in the world I can go to. I'm going to go to where I'm from, and I'm going to be an essential role to building a health system. And I'm not only going to look at just neurosurgery, but I'm also going to look at how I can impact the entire broader medical system. And because of that dedication from you, you did all of this that's helping every other physician, every other surgeon, every other nurse, and every other patient at the most important hospital in the country for the national health security of the Gambia. Thank you, Dr. Jabang. That is a wonderful thing. I just want to express my heartfelt appreciation.
Thank you so much for those kind words. Like I said, I just hope that, unfortunately, we are not good at recording and having data. I thought that would have been something that you will be able to show what the impact of getting this piped oxygen meant to the Gambia. We could have been able to show you how many people died for lack of oxygen.
We have a team that's dedicated to that, and
right.
I'm going to connect that team with you. So the team includes a young man named Samuel Miles, who came from UC Berkeley here to Johns Hopkins. His background is engineering, and he is very dedicated to that. The team includes Dr. Emma Chenard, who is the new director of the Johns Hopkins Global Alliance of Perioperative Professionals. She is a MD, PhD researcher working with the School of Public Health, and it includes a number of School of Public Health physicians and nurses who are dedicated to investigating that. And your words of encouragement right now are going right to their ears, and I will be working to help support them as we definitely do this. And there are members of the international oxygen community that are trying to advocate for these type of projects to be impactful in many other countries. And I'm sure that they're going to encourage us to do that. And I'm going to reach out to some of them to actually participate in helping to demonstrate this impact as well. So those words of encouragement that you just expressed are very important.
Yeah, so just like to also say, well, I know you've thanked me for initiation, but I also want to mention some few people who I think also made the difference. I think when we started, the chief medical director used to be Professor Usman Nyan and Dr. Roberts. We've had several meetings with them. And by the time you were coming to the Gambia, the chief medical director used to be Dr. Al-Jafari, and his deputy was Dr. Jang. And they played a very, very, very key and important role. And I really want to thank them. But I'm sure you've met Dr. Bitey. Dr. Bitey played a very key role. And I would want to just say one role he played. So as the director of health services, you notice there were two oxygen plants, in fact, currently not functioning, in a hospital called Jabang. That's currently where the neurosurgery is located. One was built by the Turkish, and I think the other one, I'm not too sure whether it's UNDP or Global Fund. But then Dr. Bite had an issue because one of them had already told him that they were going to build an oxygen plant, only for them to come and found that somebody else had built an oxygen plant there. So they weren't happy with him. So the very same people had also told Dr. Bite that we're going to build an oxygen plant at Lord Francis Small Chicken Hospital. And here am I coming to Dr. Bite to tell him that, look, Dr. Sampson and his team want to build an oxygen plant, and that's going to be the best. So for Dr. Bite to actually accept that, it was a very difficult decision. He was like, oh, UNDP is not happy with me at Jabang, John. I can't let UNDP not be happy with me at EFSD. But again, I pushed, and I want to thank Dr. Bite for finally taking the balls and actually say, okay, this project is going to be here. Because actually, this project is an all-encompassing project. And I don't think that they regret it at all. Yes, so I just wanted to say that.